Hey, good morning. I hope you guys are doing great. Today we'll be having our second lecture from the Metadidactics. Today's lecture is on the approach to hyponatremia. Hyponatremia is one of the most difficult and confusing topics that I have ever read in medicine, and we encounter it very frequently. So I decided to make a lecture on it. Okay, let's dive in. On the initial encounter, whenever we are seeing a patient with hyponatremia, we should take a careful history, including medication and diet. A physical examination should focus on extracellular fluid volume status and orthostatic vital signs, a thorough neurologic examination, lab measurements of serum plasma electrolytes like sodium, potassium, glucose, BUN, creatinine, and uric acid. Osmolality, we can calculate it or we can directly measure it through osmometry. From the urine osmolality and urine sodium holds our special interest.
Sodium is the major compound that leads to tonicity of our plasma. So if sodium is less, tonicity of our plasma is also less. There are certain exceptions of this rule, like pseudohyponatremia or hyperglycemia, where high lipid levels or high protein levels in blood can give rise to hyponatremia. We can properly measure the sodium and the tonicity by using ion-specific electrodes and directly measuring the tonicity of our plasma. To correct sodium level for hyperglycemia, we have to add 1.6 milliequivalent for every 100 milligram per dl rise in glucose level over 100 milligram per dl. The correct formula for calculation of tonicity of our plasma osmolality is 2 multiplied by serum sodium plus glucose divided by 18 plus BUN divided by 2.8. One of the most daunting tasks while treating hyponatremia is determining the cause. We will approach the cause determination through proper steps. After calculation of serum osmolality, we will start with volume assessment. We will clinically assess the volume status. We'll check orthostatic blood pressure, orthostatic pulse variation to assess for hypovolemia. High uric acid level and BUN also correlates. For hypervolemia, we can use jugular venous pressure using ultrasound, edema, or evidence of ascites. After checking the volume status, we'll look at urine osmolality. If urine osmolality is less than 100, we can say that urine is dilute and ADH is not that much active. Situations where this scenario can arise are primary polydipsia, beer drinker's protomania, or CKD, where there is volume overload. If urinary osmolality is more than 100, we can say that ADH is overactive in these situations. ADH is reabsorbing water, causing a concentrated urine, and all the major causes of hyponatremia falls in this category. For all the patients with urine osmolality more than 100, we will check urine sodium. For hypovolemic patients, if urine sodium is less than 10, we can assume that the kidneys are trying to reabsorb the sodium from the kidneys. So, this sodium is lost not through the kidneys but from some other sources like extrarenal loss, like vomiting, diarrhea, and sweating. If hypovolemic patients have urine sodium more than 30, we can assume that the cause maybe is due to diuretics or cerebral salt wasting. For euvolemic patients with hyponatremia, urine sodium is mostly more than 30 milliequivalent per liter. Causes are SIADH, severe hypothyroidism, or adrenal insufficiency. For hypervolemic patients, due to low effective circulatory volume, there is activation of renin-angiotensin-aldosterone system. That leads to low urine sodium, less than 10 milliequivalents per liter, seen in CHF, cirrhosis, and nephrotic syndrome. With this in mind, let's head to treatment consideration. Neurological manifestations of hyponatremia is typically seen when sodium level is less than 125 milliequivalent per liter. It can range from headache, nausea, to focal neurological deficit, confusion, obtundation, seizures, and brain herniation. These symptoms are mostly due to cerebral edema. Severity of symptom depends on the level of hyponatremia, hyposmolality, and the rate of development of hyponatremia. If severe neurological symptoms are present, we need to treat the patient promptly. The duration of hyponatremia is another factor that we need to consider before treating a patient with hyponatremia. There is an arbitrary cutoff of 48 hours. If it is less than 48 hours, we call it acute hyponatremia. If it is more than 48 hours, we call it chronic hyponatremia. Usually, acute hyponatremia patients are symptomatic if sodium level is less than 125. We need to treat the patient aggressively because these patients are at lower risk of having osmotic demyelination syndrome. For chronic hyponatremia, the patients already have undergone cerebral changes due to the long-standing hyponatremia. So if we treat it aggressively, there is higher risk of osmotic demyelination syndrome. So we treat this patient slowly. For indeterminate duration of hyponatremia, we always treat it slowly to reduce the risk of osmotic demyelination syndrome. For management of hyponatremia, we have a certain correction parameters. The typical rate of correction is 0.5 to 2 milliequivalent per liter per hour. Total correction, we should not exceed 12 milliequivalent per liters in 24 hours or 18 milliequivalent per liters in 48 hours. If risk factors for osmotic demyelination syndrome are present, we use a lower maximum rate of no more than 8 milliequivalent in 24 hours. Risk factors for osmotic demyelination syndrome are alcoholism, liver disease, malnutrition, hypokalemia, or severe hyponatremia less than 105 milliequivalent per liter. There is 50% associated mortality with this level of sodium. Typical estimation of infusion rate of 3% sodium chloride is the patient's body weight multiplied by desired rate of serum sodium increase. So for a 70 kilogram patient, if we desire 2 milliequivalent per liter per hour increase in serum sodium, we have to infuse it at 140 ml per hour. Or if a 70 kilogram patient requires 0.5 milliequivalent per liter per hour increase, we need to infuse 3% NaCl at 35 ml per hour infusion rate. For management of acute or severely symptomatic patients, we should be using 3% sodium chloride. We use loop diuretic along with 3% sodium chloride if the patient is at risk of volume overload. The correction rate should be 1 to 2 milliequivalent per liter per hour till the patient is asymptomatic. Correction rate per day should not exceed 8 milliequivalent per liter. Because it is a safe range, we do not go till 12 milliequivalent per liter per day. If rate exceeds this 8 milliequivalent per liter per day, we can use free water to counterbalance. The endpoints for acute treatment is when the symptoms are resolved or safe serum level, which is typically 125 milliequivalent per liter, is reached, or total correction of 12 to 18 milliequivalent per liter is achieved. For asymptomatic patients with SIADH, we can use fluid restriction or plus minus salt tablets. Normal saline can worsen hyponatremia in SIADH. So, If the patient is symptomatic, we have to use 3% NaCl plus minus loop diuretics. For hypervolemic hyponatremia, we can use diuretics and we can restrict water and sodium. For additional treatment, we can also use vaptans. For hypovolemic hyponatremia, we can use isotonic sodium chloride for volume depletion. Supplement with potassium if diuretic use is suspected. The Adrog-Medius equation can also be used to calculate the infusion rate of 3% sodium chloride. But it is true for only closed systems and does not consider urine production or sodium loss through sweat. If this formula is used while treating acute hyponatremia, we still have to monitor sodium every 2 to 4 hours. Now let's talk about the vaptans, the ADH antagonists. So the first vaptan we are going to talk about is conivaptan. It is FDA approved for euvolemic and hypervolemic hyponatremia. It is only intravenous, so we start with 20 milligram loading dose, then 20 to 40 milligrams per day. Max dose of 4 days because it interacts with CYP3A4. Monitoring frequent sodium measurements, and adverse effects are injection site reactions, headache, thirst, and hypokalemia. Next, let's come to tolvaptan. It is also used for dilutional hyponatremia, and European Medical Association has approved it for SIADH. Oral administration for short or long-term management of hyponatremia. Initial dose is 15 milligrams, further can be increased to 30 to 60 milligrams per day. Monitoring frequent serum sodium measurement just as conivaptan. Adverse effects are dry mouth, thirst, increased urinary frequency, dizziness, and nausea. So before using the vaptans, you need to consider a few facts. Like hypovolemic hyponatremic patients, we cannot use vaptans because they are volume depleted, and if we use vaptans, they are going to be further volume depleted. So they can get worsening hypertension and decreased kidney function. If creatinine is more than 2.5, vaptans are not going to work because these vaptans are not going to reach the active site where they are going to work on. And tolvaptan, this is contraindicated in cirrhosis or liver failure because it has a hepatotoxicity risk. Here is a summary of everything we have discussed so far.
So with this we end our lecture on hyponatremia. It was a long one, and thanks for making it this far with me. Please feel free to leave any feedbacks that I need to work on, and thank you.